ALL is a different disease in adults when it's compared to children. So now we have two categories. One is called AYA, which is adolescents and young adults. So my belief is patients who are adolescents and young adults, and the cutoff of age is very variable. Now, most of the clinical trials use a cutoff of 39 for young adults, but if you look at some of the other European studies, the cutoffs are as high as 50. So if you use a pediatric inspired regimen in ALL, you probably have a very high chance of curing them, and the role of transplant is not very clear. This is standard B-ALL. Now we do have Philadelphia-like ALL, which is a whole new entity. We are still learning about it. We now know that there are targetable markers for this disease. There are two pathways involved. One is the ABL pathway and the other is the JAK-STAT pathway. So there are a lot of pediatric studies and then emerging adult studies looking at the use of ruxolitinib and dasatinib upfront for treatment of these subset of patients. And we will know with time whether there is a role for transplant in this disease group or not. Now, in the Philadelphia positive ALL, I think we are shying away from allo transplant, especially in those patients who are MRD negative. But those who are MRD positive, and this is another study I'm presenting from MD Anderson group, so what they said is look at the MRD status 3 months out after hyper-CVAD and a TKI. And if you are still MRD positive, you probably might benefit from an allogeneic transplant. So our strategy at our institution is we treat them all with hyper-CVAD and a tyrosine kinase inhibitor. At the end of their induction, we do a bone marrow biopsy to see if they're in a complete remission. And I mean a molecular remission. If they're in a molecular remission, we go on to just give them maintenance therapy with 2 years of incretin steroids and indefinite use of tyrosine kinase inhibitors. If they are MRD positive by BCR-PCR, then we take them to transplant.